for giving me this opportunity to share a bit of the background um, about perhaps two things. One, what is this project? What is the overall Pain Mannequin program? And how this collaboration, how we develop this collaboration and what we have done so far. So this is definitely they are going to talk about. So Manchester Digital Pain Mannequin is it a digital pain self-reporting tool that people can use to self-report their chronic pain. So we started working on this on uh, 2018. We started working on it and we started making engagement with diverse group within the UK and who are considered disadvantaged because of their personal characteristics. And one among those was ethnicity. So we engaged with South Asian living in the UK, we explore their perspective about how what or how a culturally appropriate digital pain self-reporting tool should look like. So we capture their requirements, we gather their feedback, and that was the time when I started making engagement in the Pakistan. And I think so it all started from a very small grant application that I got from funding support that I got from the university about collaboration fund. So, and it started from a WhatsApp message when I first got introduced with Adeela, and then we started to have chat about it. And I traveled to Pakistan in September 23. We built that idea further because the purpose of that was because we thought uh, if we have captured the requirements of Pakistani people living in the UK, we wanted to see how much there is an overlap if you go to Pakistan, captures similar requirements that how what they expect from a digital pain self-reporting tool. If there is an overlap between these requirements, then perhaps a single tool can address the needs for Pakistani people living elsewhere in the world. So that was all that starting point. So with that idea, I went to Pakistan. We had an initial discussion. We built that project, and in 2024 we got this grant where we develop our mannequin further based on the knowledge that we generated in the UK. We use that knowledge to build that mannequin further. We tested it in Pakistan, and we were fortunate enough to integrate that pain mannequin in the clinical dashboard of rheumatology practice. So now is the time when we bring back the learning from Pakistan to the UK so that we could develop this tool further, which is which hopefully be an equitable tool and can address the requirements of people not only in one country but across multiple countries having shared cultural background. With that, I will stop myself and I will warmly welcome our three amazing speakers from Pakistan, and I will first request Dr. Adila to hand over this floor to her so that she could share what she has to tell us about this project.
Thank you, Muspa, for introducing this project. I am Professor Dr. Adeela Shahid. I'm here. Welcome you all on this seminar, Bridging the Divide in Pain Management in Pakistan using the digital tool. This is a series of seminars related to digital health inequities. So, a little bit of my introduction. I graduated from the Fatma Jinnah Medical University, Lahore. I did my MBBS from there, and then I proceeded for my post graduation. That is, I have done my PhD, and I'm also certified medical editor and medical educationist. And a few words about my workplaces where I worked. I worked at Fatma Memorial Hospital, Medical and Dental College in for the 5 years, and then I also worked at the University of Health Sciences, and then from 2009 onward I am at Shalamar Medical and Dental College, Lahore, affiliated with University of Health Sciences, Lahore. I'm going to talk about listening to the local voices. Musfa has given a brief introduction, and I'm going to tell about a little bit how it's all started. And the title of my talk is Listening to the Local Voices. I am here to share my experiences and the preliminary findings from the phase zero of the collaborative project between the University of Manchester UK, and the Shalimar Medical and Dental College, University of Health Sciences, Lahore, Pakistan. Pain is one of the most universal human experiences, but how it is felt, expressed, and managed, it varies significantly across cultures and local contexts. The globally validated pain assessment tools exist, but they often fail to capture how patients in different communities they describe and communicate their pain. This was the basic problem. There is no validated digital pain self-reporting tool which is available in Pakistan, and this has limited the delivery of pain management services and the coordination between patients, health professionals, and the hospitals. So, Mr. Mustafa, digital health researcher at University of Manchester, showed his interest in listening to the local voices of patients with chronic musculoskeletal pain, and he was interested in developing a smartphone-based digital pain self-reporting tool in the regional context for better pain management in Pakistan. After brief discussion, we decided to conduct this project, and he visited Pakistan in September 2023 for the preliminary work, which I would say it was a phase zero, and which began with the simple and but very powerful questions: how do people here talk about their chronic musculoskeletal pain? How do healthcare professionals manage it? And what are the requirements for digital pain self-reporting tools? What is the clinical utility of Manchester Digital Pain Mannequin? This study was conducted as a baseline research, and it was conducted after taking approval from the Institutional Review Board of Shalimar Medical and Dental College, Lahore. It was conducted to explore basically the pain experiences of patients with chronic musculoskeletal pain and understanding the requirements for a smartphone-based digital pain self-reporting tool for better pain management. For this study, the data was gathered from patients and healthcare professionals. 20 healthcare professionals involved in the pain management, such as rheumatologists, physiotherapists, anesthetists, they were invited from different hospitals in Pakistan. Face-to-face focus group discussion was done with healthcare professionals to explore how they manage chronic musculoskeletal pain and the clinical utility of the Manchester Digital Pain Mannequin. 4 face-to-face focus group discussions were also conducted with patients, 6 in each group, equal number of male and female, and they were of all age groups, suffering from the chronic musculoskeletal conditions. Discussions were audio recorded, transcribed, thematic analysis was done. In clinical settings in Pakistan, it was observed that pain is described in rich, culturally embedded language, not just through numbers or intensity scales. Patients use words, gestures, and metaphors deeply rooted in daily life. 2 major themes emerged from the analysis: pain perception and barriers to effective management and treatment. Patients felt difficulty in recalling and expressing their pain experience to healthcare professionals. When they visit them, they shared their concerns regarding the cost of medications, lack of family support, and poor socioeconomic status, resulting in non adherence to medication. The key aspects essential for accurate pain self-reporting, such as intensity of pain, duration of pain, timing of occurrence, triggers, alleviating factors, as well as physical and emotional impact on daily life, were identified. Emotional and socioeconomic dimensions of pain are often overlooked in existing assessment tools. As a result, pain experiences are frequently underreported or misinterpreted, leading to inaccurate diagnosis, suboptimal treatment, and reduced patient satisfaction. By truly listening to the local voices and the problems of the patients, we gained insight into how people express pain through their language, emotions, and in the cultural context. It revealed that pain is far more than a physical sensation. It is shaped by culture and socioeconomic factors. Most existing tools fail to capture all forms of the pain expression, leading to underrepresentation and inequities in pain assessment and management. Understanding patients' real life experiences and the barriers they face in expressing pain underscores the urgent need for a culturally adapted digital tool for frequent and longitudinal self reporting of pain, a tool that can bridge the digital divide and ensure more equitable, accurate, and patient centered care in the Pakistani context. Smartphone based Manchester digital pain mannequin was developed and tested for its usability, feasibility, acceptability, and measurement properties in the UK, and even for it was tested for the Pakistani community living in the UK. However, there was still a need to explore its usability, feasibility, acceptability, and the impact on health equity and clinical feasibility within Pakistan's social and cultural context. Hence, there was call for the International Science Partnership Fund. Application was submitted for this grant by the University of Manchester team leader Dr. Sabine. She applied and to start a collaborative project with the Shalimar Medical and Dental College, University of Health Sciences, Lahore, based on the preliminary results of the study. This it was basically this grant project. It was started to translate the knowledge regarding the development and testing of a digital pain self-reporting tool from UK to Pakistan to address the developmental needs around pain management in the local context. Collaborative project was initiated to determine the usability, feasibility, acceptability, impact on health equity, and clinical feasibility within Pakistan's social and cultural context of a smartphone-based digital self-reporting tool, which was Manchester Digital Pain Mannequin for people living with chronic pain in Pakistan. These are the members of the team. Dr. Sabine, she's the team leader. Mr. Syed Mustafa Ali, digital health researcher. Myself and Dr. Saira, she's rheumatologist at Shalimar Medical and Shalimar Medical Dental College, Shalimar Hospital, Lahore. Dr. Faiza, she's also rheumatologist. Dr. Salman is currently doing his training at US. Dr. Sharjeel, he's doing his training also, and Dr. Irwa, and the Professor Dr. Zaid, he's our principal, and co-patent Dr. Aisha Noman. This is the team behind the digital pain mannequin in Pakistan. The project was conducted in 3 phases: phase 1, phase 2, and phase 3. And phase 1 was usability and clinical usefulness of smartphone-based mannequin for daily self-reporting of chronic musculoskeletal pain. Phase 2 was related to feasibility, acceptability, and impact on health equity of a digital pain mannequin application for frequent and longitudinal self-reporting of pain among people living with chronic pain. Phase 3, assessing the clinical feasibility of smartphone pain mannequin app for chronic musculoskeletal pain management in Pakistan. This is one of the poster which I presented in the rheumatology conference last year, and it was related to the phase 0 study which was conducted in 2023. And they had a few pictures of the conference, and these are the pictures of the this project which has 3 phases. In this project, capacity building workshops, they were also conducted by Darcy, who visited Pakistan, and about analyzing the longitudinal data. And another workshop, capacity building workshop, was related to the developing equitable digital health technologies for use in research and the essential skills for managing digital health research projects. And this is all the work done related to this project. And thank you very much. And over to Mustafa. Thank you very much.
I think so. It should be between Saira and Salman, who is going to present next.
Thank you so much, Dr. Adeela, for laying out the ground that about the pain mannequin app. I will now talk briefly about the topic that was assigned to me. 1 second, I'm just sharing my. I think you can see it. One second. So, thank you for introducing me. As you know, I've been a part of the, I've been privileged to be a part of the Manchester Digital Pain App program. And I will today be exploring how Pakistan faces the digital transformation and how it is unfolding, and who are the people who are left behind, and whether this digital transformation is bridging the gap or widening it further. So,
Sarah?
this,
Sarah, sorry to
yes,
interrupt you. You are a bit quiet. Might there...
okay, can you hear me?
That's better. Yeah, it's a bit
Okay, it's a
uncomfortable for
bit
you, but it's
quiet.
much better for us, I think, if you can.
Okay, okay. I hope you can hear me better now. So I will walk you through what the promise of digitalization meant to the world globally. Talk about the digital health tools, the barriers for its implementation in Pakistan and its impacts, and then the lessons that we learned from the digital pain mannequin app, the Pakistan chapter. So basically, the promise of digitalization is of a global public good. However, the reality may be different. In the world that we live in today, it has been deemed that there is global digitalization is considered to be uh, important to bridge the gap in access, equality, and equity. And it can strengthen the systems as well as amplify the voices of underserved population and build access throughout the whole country where all of these services are not available. So basically, the theory of change, which was underpinning the framework for Pakistan's digital transformation, involved enabling the digital capabilities, investments, innovation, and policy reforms across a number of sectors, which would ultimately lead to increase in digital human development and digital impact. The reality, however, is quite different. As you can see from this important snapshot from the data from different countries, Pakistan fares at the lower end of the spectrum in all indices involving human development, e-government, inclusive internet, network readiness, as well as connectivity. We are below most of the South Asian countries and just above the sub-Saharan countries. The first level divide involves the systemic barriers. The internet penetration is only 54%. We may have a lot of internet users, but we have far more active cellular connections that are available. There is a stark rural and urban divide, and with rural populations and women being digitally excluded from these health solutions. The second level digital divide usually involves cultural and social barriers. So if we look at the computer usage in Pakistan, there is only 11% of the people will be using computers, out of which most are present in the urban areas. Out of these, 91% of the people also suggested that they did not use a computer over the last 1 week. When asked if they were proficient in using any program, most of them replied in a negative, and this was far worse for the females than was for the male. Mobile phone ownership also has a rural and urban divide is less is less as compared to computer usage. Despite 93% of the population using a mobile phone, about 60% on at least one phone. Most of them have a household phone that they share between themselves. And only about more than a quarter, 40% people own a smartphone. The gender discrepancy further widens this autonomy, in which most of the mobile phone is owned by by men, and with women having parents and guardians giving them permission for the use of mobile phones, as well as the content that they are using. So this is compounded by the low digital literacy in Pakistan, with about more than 26 million children who are out of school. Combine this with a language which is English, which is not local to the people. This leads to further worsening of the digital divide that we face in Pakistan. When we look at the internet usage pattern, most of the people use internet for entertainment purposes, and with very little using it for health and education. So when we talk about telehealth awareness and uptake, most of the people don't know that telehealth facilities are available in Pakistan. And those who do know are not available how to avail it. And this gender gap again widens where women are concerned. So what is the impact of this digital divide? It actually worsens the health equity and widens the gap further. Lack of access to digital platforms like telemedicine, electric health records, and also for digital connections for appointments leads to key information being missed out, delaying diagnosis, and therefore affecting the health of the patients as a whole. Telemedicine facilities, though available, are not used proficiently and leading to delayed diagnosis and poor treatment adherence, especially in rural areas. Doctors do not have access to electronic health records, therefore continuity of care becomes obsolete, leading to missing of or incomplete records and higher health cost and reduced patient engagement. Many services like appointments, prescription, and lab reports, which could be available locally, online portals, because of lack of digital literacy and devices or connectivity, they struggle to use them. So this is compounds the barrier of reinforcing cycles of ill health and poverty. When we talk about its impact on pain management, of course, it's going to lead to a low engagement, inaccurate pain assessment, and finally, poor pain management. Those that are excluded the most are those present in the rural areas, women having elderly population, and linguistic minorities. So for this reason, when we worked on our digital pain mannequin app, we decided to look at all the factors which could alleviate some of these inequities in health management. So Dr. Salman, who will be following me, will explain how we adapted different strategies. And I would briefly like to just explain the studies that we carried out in about 63 patients with chronic musculoskeletal pain. Most of these were women, and most were unemployed. And this statistic quite clearly shows the digital divide in Pakistan, with women's roles and economic dependency, which restricted their engagement with digital tools. When we looked at the attrition rate was more among unemployed women who had lower education level. And attrition rate, although even across all ages, was far less for people who were older than 55 years of age. When we asked the patients what impact this digital integration had on their consultations with the doctors, most said that the doctors knew the cases. And this was statistically significant. There was a slight decline about personal and social context, which could be alleviated if there was proper training for the use of the pain mannequin app. and stable satisfaction remained, showing that using these technologies did not worsen the satisfaction of patients for the clinical consults. There was a marked improvement in shared decision making after the patients viewed these digital pain self reports, and they felt that they have been heard more, included, and involved in treatment. And this ultimately felt that the patients are empowered to make the consultations more data driven and participatory. When we asked the clinicians about their reflections, they said that digital pain did help them summarize and confirm treatment successes and help them to monitor progresses. There were reports of patients missing important data in their follow-up visits, which were captured by the digital pain mannequin app. And it helped doctors aid in clinical judgment into whether to escalate or de-escalate treatment, change treatment strategies, or report benefits to the patient as well. So in conclusion, digital inclusion does not necessarily have to be about access. It has to be meaningful access. And in Pakistan, equitable digital health innovation can only be achieved through context-sensitive design, local leadership, and capacity building in digital literacy. And digital tools can bridge, not widen the divide. So I'm thankful for the Manchester team who came over to Pakistan and shared their knowledge of this digital pain mannequin app and allowed us to integrate it into our systems. And a very special thank you to Mustafa, who was pivotal in making all of this happen. Thank you. I will now hand over to Salman to explain the digital adaptations that we made in the digital pain mannequin app, looking at the local context.
Thank you, Dr. Saira. And thank you for these excellent presentations. I feel like they're kind of a good segue into where I will now kind of present a little bit about the projects, a little bit about the preliminary findings that we were able to kind of discover through our work. So just a little bit about myself. So I graduated from Fatma Memorial Medical College, and that's where I kind of had the fortune of meeting Dr. Saira, and I trained with her in 2019 and onwards during my house job. And I was here and there a bit, like did my observerships and I did my training to kind of enter into the US during that time. And in 2023, I was hired by Dr. Saira at Shalimar Medical and Dental College for a position for a research associate, and we were kind of moving forward with this project. And now I'm currently working at Jefferson Einstein Montgomery Hospital as a family physician. So this is just like a short kind of like a background about me, and I'm really interested about like research in pain and health informatics and digital health. So all of this kind of helps me. Talking about the Pakistani digital landscape, I mean, Dr. Saira has very excellently in depth kind of talked about that. I would just like to highlight a couple of things that there are like 75% of the population is using a mobile phone. Whether that means a digital mobile phone, we're not yet sure of that, but that means the penetration is there, and it's kind of like a resource that can be tapped. 45% of the population is using internet. And obviously that means that a lot of that is in the urban area. But this still, again, means that this is like a resource that, again, can be tapped into, and especially in the setting of healthcare. Talking just a little bit about the digital health policies, which Dr. Saira did mention in her presentation. Digital Nation Pakistan Act, which was passed in 2025, it does talk about a lot of digital vocabulary, and it explains it, but there is nothing about digital health specifically, what it means and how it is to be governed. Pakistan Medical and Dental Council and DRAP are governing bodies for doctors, pharmaceutical, and digital health technologies. They do provide a framework of testing digital technologies, but there is no actual dedicated legislation which is comprehensive enough to kind of like encompass the new and changing culture right now that we are in. And recently, the National Digital Health Framework from 2022 to 2030 was given by the Ministry of Health, but this is just like a roadmap to improve healthcare delivery through electronic health records, through telemedicine, and it just kind of gives a framework, but it's nothing that is kind of like concrete. So talking just like a little bit about chronic pain, I just wanted to kind of highlight what the situation with chronic pain is in Pakistan. Household survey estimated that it's around 28% of people in Pakistan face chronic pain, and it's chronic musculoskeletal pain. And it disproportionately affects women, older people, rural population, and racially diverse populations. So this was something really important for us when we were kind of talking towards incorporating the Manchester Digital Pain Mannequin into the Pakistani context, because we wanted to kind of identify the needs of these people and create and tailor our new app or the self-reporting tool in a manner that was accessible to all of these people. So just kind of like highlighting on what what background we had and how we were trying to improve it. The visual analog scales, the numeric rating scales, these are kind of validated tools. They're validated in Pakistan in multiple contexts of rheumatologic pain, cancer pain, all sorts of things. But the drawback with these is, since we are now going towards a holistic kind of explanation of what pain is, visual analog and numeric rating scales are kind of unidimensional. On the other hand, then we have the global pain scale, the brief pain inventory, the McGill pain questionnaire, which are again standardized tools. They are translated in Urdu. They're validated for use in Pakistan. However, considering that Pakistan is kind of like lagging behind on literacy, on health literacy, on what actually the contextual meanings of questions are in these questionnaires, it's difficult to capture. They are kind of like only used as kind of like follow-up visit kind of things, where the patients can enter their data, and then after like 6 weeks, when they go to the doctor again, they can re-input the data, get a kind of a score out of it, but they're not kind of longitudinal tools that can kind of input data. And they are multidimensional, but they need like a significant cognitive understanding on the patient's part, which is difficult in certain times. So kind of like going over both of these things, we try to develop the pain mannequin in a manner which kind of has the ease of the unidimensional tools, but also the multidimensionality of the other tools. So this is kind of like kind of what we try to do with the best of both worlds. So, and keeping in mind what we tried to kind of address with the digital health inequities. So we kept in mind that our local digital health literacy was poor, that we will need kind of like an extra effort on the patient's part and on our part to kind of design the app in a manner which was easy for patients and intuitive for participants to understand. Then obviously we have linguistic barriers. It's one thing to kind of like translate a questionnaire or a tool, but it's kind of a different kind of a ballpark if we have to kind of make it contextually valid for that specific population. Then talking about social cultural issues, which Dr. Saira did mention in her presentation, very importantly, that plays a huge role, especially in our part of the world. And kind of like at the end, we have resource limited settings, which kind of like play a part into all of these inequities. So talking about how we were able to kind of like go over with digital health literacy, people with chronic pain have varying cognitive and physical abilities, and it is usually seen that chronic pain affects more of the people, whether it's kind of like chronic pain caused them to have different cognitive and physical abilities, or it was the latter which caused the first thing. That is kind of like we're still in the middle for that, but it affects like they have different physical abilities, they have different levels of or lower levels of literacy, and they report more usability issues with digital health services. So keeping that in mind, we try to incorporate end user feedback into the design of the application. We try to select participants who were suffering from chronic musculoskeletal pain, and we were able to kind of like show them the application as we were designing it to incorporate what they would kind of like want to use on a daily or a routinely basis to kind of understand how their pain is affecting them. So interestingly, what we kind of like found out was they wanted like adjustable font sizes, because a lot of these musculoskeletal pains, especially the rheumatological pains, they affect the eyes, causing uveitis and things like that. So they wanted like bigger sizes. A lot of them wanted audio support in addition to like translated like Urdu and English versions. They wanted audio versions, which were like also in Urdu and English, to kind of like help them understand what each and every kind of like button on the menu was kind of like speaking to. Then a lot of the people that we interviewed, especially with with rheumatoid arthritis, have like different like hand deformities, and it's difficult for them to use the mobile phone and smaller versions of the application. So they wanted like larger slider handles to move things around. So that was something that we were able to kind of get. And they wanted an intuitive reporting designs, because like when we uh, during our focus group, when we asked patients to describe pain or what pain meant to them, they would always start with the site, then the character, then the intensity. So this was something which was kind of like similar to how everyone kind of like describes pain or how they talk about it to their doctors. So this was something that was important for them to have in the application. And this is how we kind of like had the interface that first they were able to kind of like put in the site, the character, the intensity, and then they will be able to draw on the application itself so that it was easier for the patients. It was also kind of like identified in the preliminary groundwork that people needed like pictorial representation of pain qualities to understand the context behind what qualities of pain actually are. Because when we see the translated versions of the McGill Pain Questionnaire, it's easy for someone to translate it, but it's difficult what the patient is actually perceiving behind that pain quality. So we were kind of like able to select 12 qualities from the McGill Pain Questionnaire. These were kind of the more commonly described pain qualities, which were selected by 2 rheumatologists, and concepts were developed by the rheumatologist's input, and a pictogram design, which was adapted from another research was kind of like made. And these like were given to the graphic designer to make pictograms so that people were able to click on them and we would understand what the meaning of the quality of pain is behind it. And these were obviously went back and forth between rheumatologist and the graphic designer, going to develop like multiple iterations, which were presented to the participants for their feedback. And we were able to get interesting feedback from the participant behind the meanings, how the design should be altered for that to mean specifically what the patients are trying to communicate. So we have a little bit of preliminary findings from that project as well in this. So this, for example, this was on the left, I have the first pictograms that were presented and the pain quality that they're describing, and final pictograms are on the right, which kind of like have suggestions and improvements which were gathered during these focus groups. So interestingly, what we thought was radiating pain over here at last was stiffness for most of the people. And at the end, we just changed the meaning behind that pictogram to stiffness, because that is what was most intuitive and what people thought it was. So this was really kind of like a interesting finding, kind of like doing this portion during the focus group, because there was like no right answer behind any of this, because this was also new. So this is something that we did before incorporating these things into the pain mannequin application. Talking about linguistic barriers, tools and questionnaires developed and validated in English-speaking countries, they are usually translated, but there's always a difficulty whether that translation is also kind of like giving the linguistic validity of it or the contextual validation behind it. Although there are like methods where we can do that, there is also kind of like always a difficulty in patients kind of understanding that. So because a lot of like 70% of Pakistan speaks Urdu, and there are other languages, we decided to translate it into Urdu. So we used the facet methodology for translating healthcare questionnaires. We adapted it in translating the content of the application. Now, what that means is there were two forward translations. That means from English to Urdu. Then there was reconciliation between the two translations. Then there was two backward translations by bilingual people and the discrepancies were found and removed, kind of like, so that the context was proper throughout the translation. An expert review, which included the forward translators, the backward translator, and the rheumatologists who were dealing with patient or who were patient-facing services, was done so that a finalized version was developed, which was harmonious in all settings and conveying the similar meaning to the patients throughout the application. And then obviously we had a validation during participant feedbacks when the participants were using the application. So this is something that we came up at the end. This was just like a pictorial representation of the pictograms, the English translations, the English versions and the Urdu translations that were actually shown at the end to the participants. And talking about the third inequity, which is the social and the social cultural issues. So a lot of the tools lack the social or the cultural relevance when they are implemented directly into our settings. The interesting thing that we found out that although a lot of times it seemed that when a pain mannequin or an app is impersonating or looking similar to a person, they're more likely to report pain. But what we found out during our focus groups was that female participants were more hesitant to report on mannequins which were more female looking. They preferred gender neutral, or they preferred male mannequins to report that data because of social norms, maybe comfort, and they were more able to kind of like communicate pain in that manner. And they also said that they were fine with the doctor seeing whatever their gender was and whether that pain mannequin was female for the doctor to view. They did not want to view that female pain mannequin for themselves while reporting the pain. And the other thing that we found out during like the follow-up phase where we were contacting patients was the access to mobile phones was very limited, and it was kind of like chaperoned. So for females, especially, a male relative, whether a brother or a husband, would kind of answer and sometimes deny the permission to kind of have a follow-up or to talk, to kind of like decide what kind of problems they might be having during that phase. So this was something that was really, really important, and we were able to kind of identify early on. So this was just like the pain mannequin, which women wanted to kind of like present a pain on, but not use the female mannequin. Talking about resource limited settings, these are a couple of things that like in future we can keep in mind while designing the app, that patients had limited finances and they wanted that the application not to use the data at all times. But obviously there's like back and forth in designing of the application and having that kind of local storage space. And it was like a balance between the two. But a lot of patients were hesitant to use the internet again and again daily, on a daily basis. They wanted to use it once they come to the hospital, they can connect to the Wi-Fi and then transmit the data. But that was difficult considering that it would be a significant amount of data being stored locally on the mobile device. And obviously, as Dr. Saira had said, that the inclusion of criteria of our study was that the participants needed to have their own mobile phones. So that was difficult because a lot of times patients would come in, they wanted to be enrolled, but they wouldn't be because there was one mobile phone that was being used for the whole of the family, and it was kind of difficult to tailor when the patient would have that kind of accessibility for the phone. Talking about a little bit about participant feedback as we were kind of like going through this study, it was mostly positive. Participants felt included in their health and care decisions. The interesting part was that it involving the target population allowed for immediate responses from them and their ideas and their inputs, and allowed for improvement into the application as it was kind of moving forward during the development phase. And the best thing that I feel like I found out towards the end when we were getting the end of study questionnaires was that people wanted to use the application and they felt a psychological benefit, so much so that when we told them, like obviously we told them upon the inclusion of these participants into the study that the rheumatologists wouldn't be following them, but the pain reports would be seen by the rheumatologist twice during their visits. But when we told them that the project is ending, these reports will not be seen by the rheumatologist at the future visits, they still wanted to use the application because they felt that putting that data in was kind of like a psychological relief at the end of the day, that they have done something to improve them in the regarding their pain, and they felt better, and their scores kind of like improved in that setting as well. So this was like a perceived psychological benefit of using the application on its own as well. So I think at this note, I would like to thank and kind of like end my presentation, and thank you so much to Sabine and Mustafa for making me a part of this where I could share. So I'll hand it over to you guys.
Thanks, Salman, and thank you, Saira and Adeela, as well, for your wonderful presentations. Let me stop the recording.